last lecture for Endo. We are going to do a lecture on adrenal disorders, and then we'll do a review case studies afterwards. And then I'll do a review on Thursday night as well. Okay, so adrenal disorders are objectives for today. So basically, again, looking at hormones, too much or too little of it. Cushing's, too much. Addison's and adrenal crisis are too little. Hyperaldosteronism, and then obviously hypo. And then our adrenal medulla obviously is a lot, all stimulatory. Just a review of our axis. So remember, our hypothalamus releases CRH, which then goes to the pituitary gland to release ACTH. The production of ACTH is made by that POMC molecule. Remember, the POMC dissociates to make ACTH and your melanocyte stimulating hormone. That'll come up a lot when we get to different diseases in a little bit. ACTH goes to the adrenal glands to release cortisol, and our cortisol production goes up from there. So remember the negative feedbacks and where they go. These are the zones of the cortex. Remember the glomerulosa, fasciculata, reticularis. Remember what hormones they are responsible for. Here's another picture looking at it as well. So there's two glands, the cortex and the medulla. Cortex is your cortisol, aldosterone, weak androgens. The adrenal medulla is just your catecholamines, epi and norepi. A little bit of dopamine, but not very, very much. Our stress responses. So short-term stress. Okay, a bear jumps out and going to attack you. So short-term response, it's all neurally mediated nerve impulses. We have to act quickly. Hormones take too long in the blood. They have to travel, stimulate receptors to have an effect. Short-term stress response, we want it to be neurally mediated so it happens fast. And remember, the adrenal medulla has the sympathetic innervation there so that when you do get a stressful response, the nerves go right to the medulla and get catecholamines to be dumped out. So short-term stress response, increased heart rate, blood pressure goes up, dumping glucose to the blood, dilation of our bronchioles, just things that are going to happen in a sympathetic response, breathing deep. Your eyes will dilate so you can see more things around you. Heart rate goes up, so your heart is ready to prime to start pumping more blood to your muscles to do whatever it's got to do. So short-term stress response, we're okay with that. It's supposed to happen that way. The problem is on the other side when we have a long-term or prolonged stress. This is constant stress over a long period of time. It's not once in a while. This is constant stress all the time. And in the long-term stress response, we get more of an effect with our mineralocorticoids and our glucocorticoids here. So aldosterone and cortisol start having more an effect on the long-term stress responses. We get retention of sodium and water by the kidneys. Our blood pressure goes up. Our blood volume goes up. So that's a link between prolonged stress and high blood pressure. It's the cortisol. The other side, the cortisol side of things, well, that's the aldosterone side. The cortisol side of things, protein, fat, get converted down to glucose. So we're going to dump all this sugar into the bloodstream, increase blood glucose, and suppression of the immune system. So you're not going to recover as well. You may get sick easier on these long-term stress responses. So what causes these heightened activities of the HPA axis, or what causes a decrease in the axis of this whole cascade? Stress will increase it. Here's your Cushing's. Here's some of our psych issues. Alcohol will do it. Diabetes, obesity, hyperthyroidism, these are all examples. States of decreased HPA activity, so reduction in cortisol, adrenal insufficiency, chronic fatigue, fibromyalgia, nicotine withdrawal, and so forth. So these are just examples of what would cause someone to have these things out of range. So now let's talk about Cushing's syndrome, which is high cortisol. There are 3 ways you can have Cushing's. Exogenous steroid administration. You're just taking a lot of cortisol on your own. Endogenous glucocorticoid overproduction. So we have, like, for example, ACTH producing pituitary adenoma. So within the pituitary gland, you have a tumor that's just dumping out tons of ACTH. Therefore, your cortisol will also go up from that. Another example are primary adrenal lesions. So you may have an adrenal adenoma, and that adenoma is just pumping out tons of cortisol. That's another way you can have high production of cortisol. You just have a tumor that makes it. The other way, the last one, so here's 1, here's 2, 3, ectopic ACTH. This is a tumor, usually in the lungs, and the tumor itself will just produce ACTH. And because the tumor just produces ACTH, the adrenal cortex doesn't know, is this ACTH from the pituitary gland or is it not? It just gets all that ACTH, gets stimulated, and produces tons of cortisol. So that is the 3rd way to get Cushing's syndrome. So endogenous glucocorticoid overproduction, usually due to a tumor in either the pituitary or the adrenal gland. Here are some really bad signs and symptoms of Cushing's. The violaceous purple striae, rounded face, the buffalo hump that's there. So these are very, very telltale signs of striae with Cushing's. So essentials of diagnosis, that moon face, buffalo hump, the fat distribution changes, and that's why they get the buffalo hump. Central obesity and muscle wasting. So they got a big belly and thin arms and legs. Some psych changes. Osteoporosis is big. Okay, so some of the treatments that we're going to talk about have to deal with just osteoporosis. Hypertension, wound healing is bad. Problems with glucose, hyperglycemia, all that excess glucose is going to make your blood sugar go up. Hypokalemia is a big one as well. Remember that, it'll come up later. Obviously, serum cortisol is going to be elevated and urine-free cortisol, because we have a lot of it in the system. When you test for it, it's going to be high. And lack of normal suppression by dexamethasone. Dexamethasone is just cortisol, it's just a steroid. When you give a steroid to someone, we have our normal feedback loops. What should that cortisol that I give, where should it suppress activity? Where? There's 2 spots. Hypothalamus and pituitary. If I give you cortisol, it's going to have a negative feedback at the pituitary and the hypothalamus. When you give them normal amounts of cortisol, it doesn't suppress the activity at all. And we'll get to why in a little bit. There's also this thing called a pseudo-Cushing state. They don't actually have any of the 3 causes, meaning the adrenal tumor, pituitary tumor, ectopic source, or they're just taking extra glucose or cortisol. There are some other conditions where just part of the disease causes a Cushing-like state. The big thing is, once you resolve the primary condition, the signs and symptoms of Cushing's go away. Chronic alcohol abuse. They may get some findings of Cushing's later on. You stop the alcohol, over time, the signs will go away. This is known as an alcohol-induced pseudo-Cushing syndrome. So in pseudo-Cushing, remember, there's another systemic problem that manifests in high cortisol. So your labs, high white count, hyperglycemia, and hypokalemic metabolic alkalosis may occur with really high cortisol levels. Okay. So One of the important things with labs, if they are acutely ill, do not do labs for cortisol. They're going to be higher than normal because you're sick. So if someone's ill, don't do blood work on them. If you are looking for cortisol related changes, because it's going to be high. So obviously ACTH will be up. Cortisol levels will be elevated. Urine cortisol levels are up. CBC with diff, leukocytosis are going to have elevated white count. You may want to do a low dose or a high dose dexamethasone suppression test, which we'll talk about in a little bit. An evening serum cortisol level. Why would you do a cortisol level in the evening? It should be low. So we want to see what's going on. When is a normal time for cortisol checks? In the morning, like 8:30 in the morning when they wake up. So by nighttime, it should be back down to normal and low levels. Imaging, only if you suspect it. Don't just throw imaging at everyone. If you suspect they have adrenaloma, something in the adrenal is pumping out all this ACTH or cortisol, then you can do an abdominal CT, see what the adrenals are doing. If you suspect a pituitary tumor, get a brain MRI. So whatever you suspect, scan that area, see what's going on. Your DEXA scan should be done everywhere because of osteoporosis. So just get that done yearly. So the diagnosis of Cushing's is due to inappropriately high serum or urine cortisol levels. And we look at these different things to look at for diagnosis. Urine-free cortisol level, the suppression test, how do they do? And then evening cortisol levels as well. We kind of went over already. So you suspect they have Cushing's, you do these testings, and you do your 24-hour urine-free cortisol, you do your low-dose dexamethasone suppression test. If it's normal, then everything's good. They don't have Cushing's. If these 3 lab results show an abnormal result, then you have Cushing's and you made your diagnosis and you're good. But let's say you do these tests and you're not really sure what's going on. Then you start doing more of your suppression tests to see where the problem is coming from for these patients. So the low dose dexamethasone suppression test, we give 1 milligram of essentially steroids, cortisol. And we see what happens to your cortisol levels after we give you that dose. So the low dose is 1 to 2 milligrams. The high dose is 8 milligrams. So we see how they do with both of them. A low dose suppression, so low dose suppression with no pathology. So if we give them 1 milligram of cortisol, we check the cortisol levels in a few hours, and the cortisol levels went down, that means they have normal feedback, and the pituitary and the hypothalamus were able to shut down production because I gave you some. Your body doesn't need to make any more. So I'm trying to see how the negative feedbacks are still there. So I give you 1 milligram of cortisol of the dexamethasone. I see how your cortisol levels and ACTH levels do. They should drop because I'm giving you cortisol. If they do drop, and we do have suppression with 1 milligrams, there is no problem with Cushing's because we have an accurate feedback. A high dose dexamethasone, so that's 8 milligrams, will have a negative control on the pituitary gland only, because there are still some receptors in the pituitary gland that will respond to cortisol. And at 8 milligrams, it will cause some suppression in your levels. So 8 milligram high dose suppression, we do get reduction in cortisol. The problem is the pituitary gland, because the pituitary gland has receptors for cortisol and will shut it down. So normal result, decrease in cortisol levels, and again, indicative of No changes because low dose works. So this is a good one as far as what happens with the high dose. Now we're giving 8 milligrams. If after high dose, ACTH is undetectable or low, cortisol not suppressed by high or low doses, this is a primary adrenal Cushing's. This is a problem with the adrenal gland itself or something else. If after the high dose, ACTH is normal to elevated, cortisol is not suppressed by high or low doses, we have an ectopic source. It's coming from somewhere else because there's no response. Those ectopic sources, those oat cell cancers in the lungs or whatever, they produce ACTH, but they don't have receptors for cortisol. The pituitary gland has receptors for cortisol. We want to know how much cortisol is in the blood. And if it's higher or lower, the pituitary hypothalamus will make adjustments to get your cortisol back in normal ranges. These ectopic sources don't have the receptors for cortisol. They just pump out ACTH. So by you giving cortisol, you can't suppress the ectopic source. So it's always producing. So 8 milligrams does nothing. It's an ectopic source. If 8 milligrams in cortisol is not suppressed by low doses, but is suppressed by high, we have Cushing's disease. What is Cushing's disease? It's disease of the pituitary gland itself. So Cushing's syndrome is an umbrella term. It just means you have high cortisol levels. It could be coming from anywhere. But if I say that you have Cushing's disease, that means the problem you're having is from the pituitary gland only. That's Cushing's disease. Cushing's syndrome can be Cushing's disease. It could be ectopic source. It could be you taking a lot of prednisone because you have rheumatoid arthritis. So what the underlying cause? Cushing's disease, pituitary, high dose, yes, low dose, no. Ectopic sources has no suppression at all. So if I say on an 8 milligram high dose suppression, there's no suppression of cortisol, it's got to be an ectopic source that's causing the problems. Some complications from Cushing's syndrome, too much cortisol, obviously hypertension, diabetes from all the extra glucose just floating around all the time from cortisol constantly making and dumping more glucose. High chances of infections because we're suppressing our immune system. Osteoporosis, lifelong glucocorticoid dependence if they have a bilateral adrenalectomy, meaning the adrenal gland is in hypertrophied. It's causing all this extra cortisol to be dumped out. So you can just remove that part. But if you remove the adrenals, now you have to be on glucocorticoid dependence because now you can't make cortisol. So your body has to ingest it. Kidney stones and the visual field are just from the adenoma and some psych issues. So treatment and management of Cushing's, number one, again, go to endo neurosurgery because if they have pituitary adenoma, that needs to come out. Endo to take care of all the hormonal stuff. You can do a surgical excision. We've already talked about pituitary adenomas, follows the same procedure, those transsphenoidal approach. Here's your possible bilateral adrenalectomy. Pulmonary consult, if you think it's a lung cancer that's causing the ACTH, they need to see pulmonary. If excessive use of corticosteroids, okay, I mentioned one, but there are some diseases that you're learning about, we have to treat them with prolonged use of steroids. Rheumatoid arthritis is one of them. So if you have a patient who has RA and they're on steroids for a very long time, they may develop some Cushingoid features. So you can taper them off the meds to reduce the symptoms while still getting protected with the steroid for the RA. May need potassium supplements because all the aldosterone flowing around as well going to cause hypokalemia. So they may need some potassium. And obviously watch out for the osteoporosis. So do your DEXA scans for that. Some medications, you can give an adrenal steroid inhibitor. So these block the production of the steroids. The big one is this ketoconazole or Nizoral, these antifungals. Also will act on this cortisol synthesis as well. Cytodrin is another one, but just remember adrenal steroid inhibitors are going to block the production of cortisol. We have a problem when we make too much cortisol. Let's reduce the production of it. That was really it on Cushing's. Know the symptoms, know the labs, treatment, go from there. Now we're talking about too little cortisol and too little aldosterone. So a patient with a Cushingoid feature may come to the adrenal emergency room with adrenal crisis. So what causes it? One reason, patients on steroids who stop taking their glucocorticoids. So they're supposed to be on prednisone every day, and they just stop taking it. So that cortisol is going to drop because they're not taking it anymore. They can't make it, so it can cause like a pseudo Addison's or a pseudo low cortisol because you're not taking it. Or neglect to increase the steroids during an acute illness. We mentioned before, if someone is sick, don't do a cortisol level on them because it's going to be high. Why is it high? Because you need the cortisol to help with the stressful response of being sick and getting through the illness. So if someone already has Addison's disease, where they know body doesn't make cortisol anymore, they're going to take a daily dose of prednisone every day or another drug. If they feel themselves getting sick, they're getting stressed out in PA school, they got a bunch of exams coming up, they need to increase the dose of the cortisol to handle the stress that's going to be happening to that person. You didn't get this joke yet because you didn't understand that. They have to increase their cortisol under a stressful response because their body doesn't make the cortisol. So if they're under a stressful response and they don't increase their cortisol, it's going to mimic a low cortisol environment because their body needs more of it to handle the stress, but they're not making it. So it shows as being low. It may also occur in patients who have recently undergone. So here is an ACTH producing or a cortisol producing tumor. So they have ACTH producing tumor or a cortisol producing tumor. So we put them on an adrenal steroid inhibitor, ketoconazole, okay, in preparation for them going for surgery to handle the adrenalectomy. They go surgery, they have it, all of that tissue got taken away. So cortisol levels are going to go down. And they're taking adrenal steroid inhibitors. What's that going to do to your cortisol levels? Drop it as well. So you got two things that are dropping your cortisol levels. You're having surgery to remove the tissue, and you're on a medicine that's also going to make your cortisol levels low. And it doesn't happen all the time, but it can happen. But if they've undergone a bilateral adrenalectomy, watch out for signs of adrenal crisis because their cortisol levels were normally at a certain level high for a long time, and now we're dropping it lower rapidly because they went surgery. That drop may be enough to put them in a crisis. Physical exam findings for adrenal crisis: hypotension, abdominal pain, vomiting, mental confusion. We have some hypoglycemia. Now we have hyperkalemia. Why do we have hyperkalemia now? What don't we have? Aldosterone. What does aldosterone do to potassium? Excretes it. If we don't have aldosterone now, all this potassium is going to start building up in the blood. That's also why you get hyponatremia. And that's also why we don't get hypertension, but so hyponatremia and metabolic acidosis. It's the lack of aldosterone. So adrenal insufficiency, known as Addison's disease from 1855 because of Thomas Addison. So if you find a disease, you can name it after yourself. Whenever someone's talked about Addison's disease, it's chronic. It's the chronic version of it. Adrenal crisis is the acute form of it. Addison's disease, you can live with it for a very long time, as long as you just take your meds every day. Adrenal crisis is a life-threatening emergency that has to be dealt with rapidly, and we'll go through that in a second. So what causes adrenal insufficiency? Just either destruction or dysfunction of the entire adrenal cortex. It's going to affect our cortisol and aldosterone. If you ever see this, antibodies to 21 alpha or 21 hydroxylase enzyme, that 21 hydroxylase enzyme is very specific for Addison's disease. I don't have the picture in this one, but if you remember from physio, we went over that big pathway where cholesterol starts it, then pregnenolone, and then you get to progesterone, I think, and then it goes from there. 21 alpha hydroxylase is the enzyme that allows you to get to the cortisol and aldosterone pathways. If you don't have that enzyme, you can't make cortisol, you can't make aldosterone. So all your precursor hormones go towards androgens because you're not making it with cortisol, you're not making aldosterone. So all the ingredients that you have just all get dumped into androgens. You don't start getting symptoms and disease until about 90% of both cortexes are either dysfunctional or destroyed. So 90% of both adrenal cortex must be destroyed before you start getting some problems. There's also some autoimmune destruction. And so adrenal cortex antibodies is what you'll see if it's an autoimmune problem. So President JFK was thought to have Addison's disease. Common presentation between 30 and 50 may happen earlier if they have some these other syndromes, which we'll go over in a second, or congenital adrenal hyperplasia as well. So this is an important one because this is another one, like it's not multiple endocrine neoplasias, but these are polyglandular diseases, meaning multiple glands are affected. So the first one you got to know, Schmidt syndrome, Addison's plus Hashimoto's. So if they have Addison's disease and they have Hashimoto's, that's called Schmidt syndrome. If they have Addison's disease with hypoparathyroidism and mucocutaneous candidiasis, now we're dealing with some sort of skin infections here. That's polyglandular autoimmune syndrome type 1. Parathyroidism, Addison's, and a skin infection, mucocutaneous candidiasis. If Addison's disease with type 1 diabetes and either Hashimoto's or Graves' disease, one or the other, that is polyglandular disease type 2. So those are 3 more little combos of diseases you got to know. So we had the 4 MEN diseases. Now we have 3 more: Schmidt, polyglandular type 1 and type 2. You'll see these pop up. Well, really this one. I think it was on that Ozempic commercial we listened to. It said, don't take Ozempic if you have polyglandular autoimmune disease type 2, because it's of the type 1 diabetes problem. Okay. So additional causes, TB was a very common cause for a long time for Addison's disease. There's some malignant infiltration of the cortices, either your Hodgkin's or non-Hodgkin's lymphoma will also affect that. Here's our metastatic cancers, and your amyloidosis and hemochromatosis are some other causes for Addison's disease. All the patients complain of progressive weakness, fatigue, poor appetite, weight loss. Those are the big ones that are to happen Then you have some other ones, your nausea and vomiting, some GI distress, dizziness with orthostasis, they're going to be hypotensive. Maybe have some vitiligo due to that hyperpigmentation. It looks like vitiligo, but it's just hyperpigmentation. Remember, vitiligo, I think, is the absence of the color. This is the hyper color. And then they have some myalgias as well. So history, look for onset of symptoms. Hyperpigmentation and of the mucous membranes in the skin may precede all other symptoms. Why? Why would that precede everything else? What do we have an abundance of trying to get our body to make more and more cortisol? ACTH. But remember, we don't have any really major signs and symptoms, so about 90% destruction has occurred. That's due to cortisol not being produced. But ACTH will slowly build up and up and up and up and up, trying to get the cortisol levels to be productive. And while that's going on, you're making a ton of MSH as well, all along the way. So that's why this hyperpigmentation might be the first sign. They may say, you know, your patient, well, you look very tan. You get back from vacation. You're like, no, I didn't go anywhere. I just look tan. And they were never before. Maybe they're having a problem with this because now they're pumping up MSH. Why are you tan when you ain't going to the beach? What's going on? So figure those things out. Very prominent on sun-exposed areas of the skin, extensor surfaces, and so forth. Also seen in palmar creases and nail beds, mucous membranes. So this is just random pictures here of the hyperpigmentation. This looks a tan, more tan than the other arm. Vitiligo, buccal mucosa, and then your palmar creases here. More just signs and symptoms you may see from Addison's disease. So how do we diagnose this? We want to see, can your body make cortisol? So rapid ACTH test. I'm just going to give you ACTH. What should I see in a normal person if I give you ACTH? What should happen to your cortisol levels if I check it in an hour, 2 hours later? Should go up. That means your body's responsive and you're making cortisol. If I give you ACTH and your cortisol levels don't go up, that means your body is not responsive to ACTH and your cortex is not stimulated by it and you're not making any cortisol. So if you get rises in cortisol and aldosterone, it talks about the integrity of that adrenal cortex. In patients with Addison's disease, minimal or no changes in response to the ACTH. So with this lab, ACTH will be up because it's trying to stimulate the cortex to make more cortisol. And obviously cortisol and aldosterone are down because they don't have the tissue to make it. Or they can't have the enzyme to even get into the door to make it. Electrolytes, important one. Remember, sodium is going to be low. Potassium and calcium, mainly the potassium, is going to be elevated. Some kidney involvement as well. Glucose checks. Check your thyroid, that may be elevated as well. Some imaging, chest x-ray, may have a small heart, but if you think they have TB, get a chest x-ray. What do you want to look for in the chest x-ray if you suspect TB? What are those little things called? Gone complexes, right? If you suspect they have an adrenal gland problem, that congenital adrenal hyperplasia, then get your abdominal CT, see what the scans or the adrenal cortex are doing. In idiopathic autoimmune Addison's disease, because our body is attacking our own tissues, the adrenal glands are usually atrophic. They're going to be smaller because our body is attacking it, killing the cells, so you're going to have less mass. It'll get smaller. So treatment. They have to replace this stuff. So the main one we give is hydrocortisone, Cortef, or hydrocortisone, the drug of choice for steroid replacement and for acute adrenal crisis and for daily maintenance. Remember, they have to take this every day. I can't stop. Now, the reason why this is the drug of choice is because hydrocortisone has both glucocorticoid and mineralocorticoid activities. It's going to help not only the cortisol, but also the aldosterone as well. Florinef, fludrocortisone. is just aldosterone. This is also known as a volume expander. Why is it a volume expander? I'm giving you aldosterone. What's the job of aldosterone in water? Retention. So it's a volume expander. It's going to expand your volume to bring your blood pressure back up again. And then you have your, these are your straight glucocorticoids. So deltazone, steripredione, orezone, the prednisone is just cortisol. Florinef is just aldosterone. And the hydrocortisone does both aldosterone and cortisol activity. So they're going to have to be on one of these drugs for life, maybe two, depending on what one you put them on. But if they're just on the hydrocortisone, that's fine. You would probably give them a side dose of prednisone as a pill in a pocket, meaning if they feel themselves getting sick or undergoing surgery where they have a very stressful environment, they can take extra cortisol, extra prednisone to help with that stressful environment. So they need to be on glucocorticoid and mineralocorticoid replacement for life. And basically increase the dose, titrate a patient's well-being, and the presence or absence of symptoms. So it's really how does the patient feel? Same thing with thyroid is how they feel, but you're trying to get it in that TSH range. Here's more symptom management. Some may not need the fludrocortisone replacement, but the cortisol must be replaced. The aldosterone, depending on how their blood pressure is doing, but the cortisol, prednisone is the minimum. Hydrocortisone to do both, but if they're on just the prednisone, they have to probably during some time the Florinef as well for the aldosterone help. So close monitoring, talk to your patients about signs of inadequate replacement, morning headaches, weakness, dizziness. That's not getting enough cortisol. Or signs of over replacement. Now they're taking too much. Now they're going to get those Cushingoid features now. The moon face, buffalo hump, the striae, those things, if they're taking too much cortisol for their Addison's disease. So you can go from Addison's to Cushing's just by taking too much prednisone. So patient education is very important. Make sure they understand they have to take it every day. They have to increase during periods of stress and whatnot. They have to wear a bracelet. Okay, one of the signs they're going to come in with, they're going to be altered mental status or even obtunded in a coma. If I did not wear that bracelet, you would have no idea that all you had to do is just give me some cortisol and I'll spruce right back up again. That's not a normal thing you give in the ER. But if I know they have this, when they come to the ER, we'll go through the treatment in a minute, but they're going to get some cortisol because that'll help spruce them up again. So adrenal crisis. Now we're in the acute form of the low cortisol, low aldosterone. 8% of people with Addison's will get some sort of hospitalization at some point due to adrenal crisis. If not treated promptly, death may occur. And what will cause adrenal crisis? Usually a new event, adrenal hemorrhage, or superimpose on top of already existing insufficiency. So most common cause is usually stress. Okay, and what are they not doing? Increasing their dose. So during periods of stress, they need the extra cortisol. They're not taking it. They'll put themselves in adrenal crisis because the amount of cortisol their body needs, they're not producing. And just like with DKA with type 1s, 25% of Addison's will show up in adrenal crisis. So failure to appropriately increase daily replacement steroids will cause adrenocortical insufficiency. You're not taking the extra that your body needs. The other cause is bilateral adrenal hemorrhage. It's due to infection, pregnancy, anticoagulation, and whatnot. So this is the big pathway of what the problem is. Let's start right here. Okay, our adrenal glands aren't working very well. And we know there are two major hormones we have to worry about, cortisol and our aldosterone. Let's focus on cortisol first. We don't have it. Liver function starts to decrease. We don't have cortisol to stimulate it, therefore leading to low blood sugar. Having low cortisol will also cause some digestive enzymes to decrease. Remember, cortisol, during high amounts of cortisol, they get acid reflux from the excess gastric acid. Now we're dropping it. We don't have the cortisol, mainly some vomiting, diarrhea, and cramps, which further makes low blood volume, making your blood pressure lower, which can lead to shock, which can lead to death, again, untreated. Extremely low sugar, coma and brain death, if you don't treat it. So these are the two major problems when you don't have cortisol. That's why you have to treat that one faster. On the aldosterone side, we get kidneys. The effect there is water and sodium loss, which further makes your low blood volume, which further makes the shock worse, which further increases your risk of death. Makes sense as we follow it along, why we need to replace it? Further, kidney water sodium loss, and also we also get high potassium is in it also in here, will cause some heart irregularities, which will also cause issues with your blood pressure because our hemodynamics are compromised. We're not going to get the outflow that we need, which further leads to shock, which further leads to blood pressure, to brain death and coma. So this is the pathway. Understand this, why you have to treat with steroids so fast, because you want to prevent all this other stuff from happening due to the low cortisol and aldosterone. So how are they going to present? Nausea, vomiting, vascular collapse, maybe in shock, cyanotic. They may have some symptoms that resemble an acute abdomen, may have hyperpyrexia, comatose, and if they have acute adrenal hemorrhage, hemorrhaging in the adrenal gland itself, sudden collapse, flank pain, and nausea as well, with or without fevers, but that's rare that happens. So in acute adrenal crisis where treatment should not be delayed in order to do the test, random plasma cortisol levels should be drawn prior to starting your replacement therapy. So just get it done real fast, and then you're going to replace it anyway, but just get a random cortisol level, get a random tube and see what's going on. Because you know, once you start giving your cortisol, that level is going to go up again. And if I measure you the next day, it's going to be artificially high because I loaded you up with a bunch of cortisol. So they're going to come into the ER, they're going to get labs done first anyway, check the cortisol, add it to that lab, and go from there. But labs will show low cortisol and high ACTH. ACTH is trying to stimulate the cortex to pump out cortisol. So treatment, IV access, get started early and start normal saline fast. And then you'll start IV hydrocortisone or the succinate or the phosphate, which is the Corta. Hydrocortisone for 5 to 7 days, and then you wean them off to the oral one. So they'll be on the IV dose while they're in the hospital, but then you'll start to transition them to the oral med because they're going to have to go home on the oral medication. Especially if they came in and never knew they had adrenal crisis or adrenal Addison disease, they won't be on that medication. They're going to have to go home on it. So they'll start it in the hospital, wean it off, and then IV gets weaned off for the orals, and then they go home on the oral. Prevention, talk to your patients about giving themselves extra doses when they need it for high stress. Obviously, the IM version, if they can't do any oral intake because of all the excess vomiting due to the low cortisol. Um, no adjustment needs to be made for the aldosterone in stressful situations. It's just the cortisol that needs to be adjusted. So if you have an exam question that says patient coming in, they have Addison's disease, and they're going for a major exam or a surgery, what meds should be increased? You don't need to worry about the Florina, the fludrocortisone. That's just for aldosterone activity, and that does not need to be increased during periods of stress. Just the prednisone. Okay, any questions about cortisol, high and low cortisol? Okay, you guys want to take a break? Okay, come back in 10 minutes. Okay, so we'll get started. We'll finish up. We don't have that much left to do. Um, so we talked about cortisol, to high cortisols, Cushing's, to low cortisols, Addison's disease. Now we'll discuss aldosterone by itself, and again, too much or too little of the hormone. So when it comes to hyperaldosteronism, there's two ways to look at it, and it all depends on where the aldosterone is coming from. Primary hyperaldosteronism, excess aldosterone production. So in primary, we just have too much aldosterone being made by our body. It's the most common cause of secondary hypertension. So patients who have refractory blood pressure, you're giving them all these medications and their blood pressure is not coming down, so check kidneys and check aldosterone levels. Because if you have an aldosterone secreting tumor, what is all the aldosterone going to do to your water? Dump it out or keep it in? Keep it in. What's happening to your blood pressure? It's going to go up. So that is primary hyperaldosteronism causing secondary hypertension. You treat the aldosterone problem and the blood pressure comes back down and they're okay. 5 to 15% of blood pressure are due to primary hyperaldosteronism. Conn syndrome, if you ever hear of Conn syndrome is primary hyperaldosteronism secondary to an adrenal aldosteronoma. So Conn, essentially cancer cells. Think of it. It's cancer of the adrenal gland causing the production of aldosterone. So Conn syndrome is the actual disease due to aldosteronoma. Most common causes, again, are these aldosteronomas, again, these aldosterone secreting tumors. And the second one is bilateral idiopathic adrenal hyperplasia. Now, the adrenal gland is thickened and it's enlarged. And when they have a thickened and enlarged gland, they're going to produce a lot more hormones. And in this case, it's all aldosterone. So you have to figure out what the cause is, because the treatment is going to be different. If it's an aldosteronoma, you just remove it. You take it out the tumor and they'll be okay. If it's bilateral idiopathic adrenal hyperplasia, they need medical therapy with aldosterone antagonists. So most of them are going to be these aldosterone tumors. You just remove the tumor, but if it's not, if it's the other one, hyperplasia, you need to put them on these these aldosterone antagonists. This is the main one I want to focus on. This is right from physio, not physio, but mainly from pathophys. So we have this tumor right here. And that tumor is dumping all this extra aldosterone into the system, which causes sodium retention and increases our potassium loss. Sodium retention is going to do what to our blood volume? Increase our blood volume. When we have a high blood volume going to the kidneys, what apparatus, what structure in the kidneys senses blood volume status? Macula densa. Macula densa in the kidneys senses all of the pressure coming in. And if the pressure is high with sodium retention, we don't need more blood volume, so the renin goes down. Low renin is very important with primary hyperaldosteronism. You'll see what difference the other one shows. And then because we have low renin, we have low angiotensin II as well. So this is how primary hyperaldosteronism leads to blood pressure issues. This is just the example of how the whole cascade happens. That's just review on the right side. Here's another thing that happens with all this aldosterone excess. Potassium loss. Remember, aldosterone, potassium goes in, sodium and water come back, goes back in the body, potassium goes into the urine and out. So we get potassium loss, which can cause some cardiac issues, causing some diastolic dysfunction, which leads to cardiac failure and further heart failure, congestion going on. So this is away from having too much aldosterone can lead to heart failure. Aldosterone excess also causes problem with our vasculature and sodium water retention, leading to hypertension, which further makes the LVH worse, further makes your diastolic dysfunction worse, and so on and so forth. So you can see here how this aldosterone excess places a big load on the heart, a lot of volume on the heart. Heart's got to squeeze all that through. The pressure goes skyrocketing. And you get congestion, and eventually heart failure starts to occur. So with primary, when should you consider primary hyperaldosteronism in a patient with hypertension? So when would you suspect primary hyperaldosteronism to be the cause for your hypertension? Hypokalemia on lab results. People should not be normally hypokalemic, but if they are and they have high blood pressure, makes sense. Aldosterone may be the culprit because it's going to do those things, because they're going to be hypertensive. If they develop severe or persistent hypokalemia with low doses of potassium wasting diuretics. Which ones are the potassium wasting diuretics? Spironolactone sparing. And basically everything else. Everything else is potassium wasting. The only one that's potassium sparing is your spironolactone. If they have refractory hypertension, except in the beginning of this segment, you're trying all these drugs on them and nothing is touching their blood pressure. You went to ARBs, ACEs, beta blockers, calcium channel blockers, diuretics. Nothing is lowering the pressure because they have this underlying aldosterone problem that will always win over those pills. And any family history of primary hyperaldosteronism will also be a reason as well for you to suspect it. Physical exam findings: hypertension, weakness, distension, ileus from the hypokalemia, maybe some GI problems, and other issues with hypertension itself. Because whether it's hypertension is hypertension. It doesn't matter if it was caused by a pheochromocytoma, stress, hyperaldosteronism. It's high blood pressure on the system, so they're all going to have the same symptoms over time. Labs and imaging: 24-hour urine will have high amounts of aldosterone. Your electrolytes will show high aldosterone, hypokalemia, hypernatremia. That's the effect of aldosterone. Renin is going to be very, very low. We're trying to compensate. So renin drops to almost nothing. And you get your CT scan of your adrenal glands. And that will tell you, is this an aldosteronoma? And what's the treatment for the aldosteronoma? Remove it, surgically excise it, get it out. Versus hyperplasia. If it's adrenal hyperplasia, how do you treat that? Meds. Okay, you block the production of aldosterone with those patients. So the treatment is different. You have to know, is this an aldosterone tumor or is it just thickened tissue? Treatment, we just went over. And again, always get endo and surgery involved for your patient. That's it on primary hyperaldosteronism. Now we'll talk about hypoaldosteronism, too low aldosterone. Risk factors: chronic renal disease, so they usually go hand in hand. Diabetes, which leads to kidney disease. Medications can do it. NSAIDs, ACE inhibitors, diuretics can cause hypoaldosteronism. Signs and symptoms: postural hypotension. Why are they going to get postural hypotension? What do they not have anymore? Blood volume, right? Because aldosterone is to help bring the blood volume back, but we don't have aldosterone. So we're going to lose all the water and the sodium in the urine. They're going to be hypotensive, So when you do your orthostatics and they stand up, they're going to get lightheaded and dizzy. Anorexia, weight loss, due to the GI upset, dizziness as well. Labs, just the opposite. Aldosterone will be low, hyperkalemia, hyponatremia. Renin is going to be high in this case. Trying to compensate. We have low pressure, low volume coming into the kidneys. What structure in the kidney is going to sense it? Macula densa. You guys are doing nephro in a couple weeks with Ovalle. Get ready. So all the stuff like better come back. Review it. So renin was going to go up to realize, hey, we're not getting enough blood volume in the kidneys. Let's pump our renin, try and get the aldosterone going to get our blood volume back up. Treatment, endo nephro, for this case, not neurosurgeon. This is a different one. They go to nephrology for this one. Your fludrocortisone, is this aldosterone activity, glucocorticoid activity, or both? This is just aldosterone. So you don't have aldosterone, we'll give you aldosterone. We give you fludrocortisone. Liberal salt intake. Just add salt to your food. This is one time you actually will tell your patients, add salt to your food, because they need the salt in their food to get their blood pressure back up again. So that's the treatments for that. Last one is our pheochromocytoma. Rare catecholamine secreting tumor from the chromaffin cells. Often in the adrenal gland, that's 90% of them. So because they get excessive catecholamine secretion, they may precipitate life-threatening hypertension or cardiac arrhythmias with these pheochromocytomas. So precipitants of a hypertensive crisis include anesthesia induction. Why do you ask your patients? One of the reasons you ask your patients, why have you ever had any surgery? We ask just to know their anatomy, see what's missing. Past complications. If they went through anesthesia once and they got out of it and they had no problems, my likelihood of them having a feel is very low because they've already gone through surgery once. They went through anesthesia and they came out of it okay. If you're prepping someone for surgery, and you guys will start surgery tomorrow, all the pre-op questions like, have you had any recent surgeries? Okay, now if you're doing it from a surgical perspective, you would want to ask, do you have any complications with anesthesia, any problem with the surgery, recovery, whatnot? That's kind of what we're talking about here. So if you have a pheo and you induce anesthesia, you can make a hypertensive crisis due to that. Opiate, dopamine agonist, antagonist, cold medicines can precipitate blood pressure issues. Next time you go to Publix, go to, or wherever you go shop, look in the pharmacy aisle, and you'll look at the cold medicines. And you'll see some that have like, I think it's quercetin BP is one of them. The BP is for blood pressure. Quercetin won't raise your blood pressure, but it's a cough medicine. So you can give that cough medicine to people who have blood pressure problems. It's made for that. So that's why cold medicines can cause that reaction. Contrast dye, TCAs, cocaine, these block the uptake. So if you block the reuptake of the catecholamines, where's the catecholamine going to stick around longer? In the blood. We already have too much catecholamines in the blood. We don't need it there. So the TCAs will make the pheo worse because its catecholamines will stick around longer. Childbirth is another one that will cause blood pressure to go up. The big three symptoms: headaches, palpitations, and diaphoresis. Okay. And I think I have it somewhere else. Yeah, it's there. With severe hypertension, the episodes will vary. Sometimes it may only happen once a month. Sometimes it can happen daily. The duration may vary from seconds to hours. But as the tumor grows and gets bigger and bigger, these episodes will happen more frequently because the tissue is growing a lot and there's more dumping all these catecholamines going on. So here's your PHE is the mnemonic: palpitations, headache, and episodic sweating. There are more, but those are the big ones for that. BP will be elevated and fluctuating. Systolic can get as high as 300. Okay, so that's very, very, very high. Physical findings, again, hypertension, usually paroxysmal in the majority of the cases. They may have some postural hypotension as well. Hypertensive retinopathy, again, any sign or symptom from prolonged high blood pressure you may see here. This is a big one here, these neurofibromas or these cafe au lait spots. I have a picture of that in a second, but there's a big correlation between people who have pheochromocytomas and a large number of these cafe au lait spots or neurofibromas. Have you ever heard of the Elephant Man? So the Elephant Man was a real person. The Elephant Man was a derogatory nickname for that person. They actually had neurofibromas. It wasn't like bone. It was the or the nerve endings were. They grew from there, and it caused all the problems from happening. Pulmonary edema, cardiomyopathy. These are the cafe au lait spots. Everyone, it's a weird evolutionary thing, but like everyone has like one somewhere on your body, but not multiple of them. If you have multiple of them, not saying you have a feel, but if you come in with crazy blood pressure spikes and you notice those things, then you put two and two together, they may have it. But don't think, oh, if you have a bunch of these, you have feel. Imaging, 24-hour urine collection is the big one for pheochromocytoma. We want to know how much is being dumped and you're producing in a 24-hour period. You're going to see total catecholamines, and we're going to see this vanilla mandelic acid, the VMA, which is a byproduct of the destruction, the metabolism of the catecholamines. So if you're producing a lot of catecholamines, you're going to have to metabolize these catecholamines. You will produce VMA, which then you'll use as a marker. Catecholamine is obviously going to be elevated in the blood, and you do your CT scan, and you'll see a tumor in the adrenal medulla. And then I think this is the mass right there. Yeah, because there's the kidney. Okay. Treatment, just take it out. Now, this is the important part right here, this next part right here. We have to give alpha and beta blockers prior to surgery, but there's an order that you have to do it in. You only give the beta blocker after you've effectively blocked all the alphas first. So alphas are first, beta is second. If you start your beta blockade first, you get unopposed alpha stimulation. And what does alpha stimulation do in the vessels? Constrict. And what's that going to do to your blood pressure? Make it worse. So you block the alpha first, because alphas are in the periphery, in the vasculature mainly. Let's block that first, and then we block the beta, and then you can go for surgery. So remember that, alphas first and then betas. So to review, these are the things we went over. These are little review as far as what you're looking at between cortisol and ACTH, depending on what disease we talked about in our HPA axis. Okay, let me stop this and I'll pull up the review and then we'll go from there.